Again, these are my financial disclosures, and I do not have any financial interest in the following topic of regard. Why do I prefer Pre Descemets Endothelial Keratoplasty? Its advantages over DSEK, DMEK and PK. As we know, the human corneal anatomy was redefined when Dr. Dua demonstrated with the Pre Descemets separation of the cornea, endothelium and the Pre Descemets layer. You can see, even with stripping of the Descemets membrane and the endothelial complex, you find some tough resistant area over the bubble under the Descemets layer, and he called it as Dua's layer or Pre Descemets layer. He proved the existence of Dua's layer with various microscopic studies, the sixth layer getting added to the corneal anatomy. It was Professor Amar who made this particular thing into as a surgical innovation, where he used an air-filled syringe to make a Pre Descemets separation and used this Pre Descemets separation as a base for creation of a graft tissue, which we called it as the Pre Descemets graft for endothelial keratoplasty. Here I went ahead with one of the cases, 56-year-old female with Fuchs endothelial dystrophy. One of the eyes was affected. As I said, I went in with 26 gauge needle, made a Pre Descemets separation. I stained the space with trypan blue. I always mark and go alongside of the marked zone to make a 7.5 to 8 millimeter Pre Descemets graft. You can still see the edges of the graft, not too much bad. I went ahead with the microphacoemulsification, loaded the graft in Medicel injector, MI60 injector. After removing the spring, did a conventional descemetorexis on the recipient, injected the graft, and after which the graft unrolling and attaching properties are similar to that of DMEK, with one thing is that the graft has got adequate tough tissue, the Pre Descemets layer, which gives some more support like DSEK. So this was on post-op day 1. This was in 2014, if I remember. This was my first case of PDEK, and it went on well with an young donor cornea. This is one another case which was a failed corneal graft with a bad endothelium. Went ahead, did a cataract surgery, removed the deceased endothelium Descemets, used a PDEK graft. Use of endoeliminator is really a big help in endothelial keratoplasties. Unrolled the graft and attached. And this is how after 6 months the patient behaved. This is one of the cases of one of my colleagues in our peripheral center who did an iatrogenic descemetorexis substituting a capsulorexis. So in this particular case, when it was referred to us, he sent it along with the Descemets membrane also. You can find the extent of descemetorexis extending to the section. I made a capsulorexis, removed the residual Descemets, did a Pre Descemets endothelial keratoplasty on the second day, and the patient did very well. We also tried Pre Descemets endothelial keratoplasty in cases with iridocorneal endothelial syndromes and pseudoexfoliation syndromes with endothelial dysfunctions, and this is how they all behaved. I also tried in couple of cases of post hydrops case, post Descemets rupture and hydrops, where I removed the Descemets membrane and replaced with a small faint scar. Still I was able to get a very good endothelium and Descemets in place. We also included cases of post-RAP glaucoma with endothelial dysfunction in our study, and we did Pre Descemets endothelial keratoplasty. You can see as has been mentioned, some little raggedness is seen because of excision of the graft, but still it is relatively circular. So coming to donors, in my study of 58 cases, more than 80% of donors were less than 50 years of age, which could not be a case if I had done DMEK in all these cases. So any donor age is not a compromise, except for one thing, that donor tissue, as the age goes down, tends to make a triangular morphology. The graft tends to assume a triangular morphology, becomes little difficult to unroll. Rather than that, creation of Pre Descemets graft is not at all a big issue as compared to DMEK. So a pneumatic separation of Pre Descemets space is superior to mechanical dissection as in DMEK. This was what was our inference. Comparing the central corneal thickness, this is based on the historical samples what we had taken. Our study showed 565 as mean corneal thickness, which was almost similar to that of DMEK. So I would state both the cases, both DMEK and PDEK, but for 20 or 30 microns, 20 microns of additional tissue, they get back the corneal thickness, the central corneal thickness, to a normal level when compared to DSEK. DSEK, the value, the historical sample, the value is 680 microns. 618 as a mean can result in hyperopic shift in the post-operative phase. The visual acuity, preoperative visual acuity in our series was 1.4 logmar units, and which improved to 0.35 in a mean, and you can see only 3 cases lied outside the confidence interval, and of which 2 had graft failure, which required repeat injections of air bubbles, or rebubbling was high, and 1 was a primary graft failure because of the quality of the graft tissue which I used. So this was very fascinating for me to look at. The endothelial cell loss by 6 months was 23% in our study, and which was supposed to be higher in DMEK and DSEK. This is probably, again, pneumatic separation is superior to that of mechanical dissection. This is another study by Ham, who postulated 24% of DMEK cell loss by 6 months, and the price group is 33% by 1 year. So ours is no way inferior to DMEK in terms of endothelial cell loss. So again, pneumatic separation acts superior to that of mechanical dissection. So when I compared with PK, patients can feel the quality of surgery. The procedure is done most often under topical anesthesia. It's a pain-free procedure. It's a daycare surgery. No admission is required. Back to routine activities in a week or 10 days. When compared to PK, it is 6 to 12 months with rehabilitation, and of course there are no suture emergent adverse events noted in our study. So pneumatic dissection of Pre Descemets layer in endothelial keratoplasty is easily reproducible when compared with DMEK. Any donor age, that's a great boon when compared to DMEK, restores the cornea to a normal central corneal thickness. There are no suture emergent adverse reactions, even astigmatism, as compared with the PK, and also it is no way inferior to standard procedures of DSEK or DMEK in endothelial preservation. So earlier my practice was manual DSEK, then was DMEK, and finally the present day practice of mine is Pre Descemets Endothelial Keratoplasty, and of course endo eliminator is an essential component in my all my endothelial keratoplasty surgeries. However, I do not use forced infusion air pumps as Dr. Sumati does, but endo eliminator, of course, yes, is a boon to my endothelial surgeries. Thank you for your attention.